My name is Fausto Pinto. I'm the president-elect of the World Heart Federation. Actually, from the 1st of January, I'll be the president of the World Heart Federation. I'm a cardiologist. I'm based here in Lisbon, Portugal. I'm the head of the cardiovascular department at the University Hospital, and I'm also the dean of the medical school. And it's my pleasure to have with me today a very nice panel of colleagues and also a patient representative. And I have with me Professor Ali Taher, he's a professor of medicine at the American University in Beirut, Lebanon, and he's a hematologist and a well-known and renowned expert in the field. Professor Antonio Almeida is also a hematologist. He's based in Lisbon. He's the head of hematology at the Hospital de Luz in Lisbon, and also at the Institute of Oncology in Lisbon, Portugal. And he's the secretary of the European Hematology Association. And then Mrs. Aiste Staraite, she's the president of Patient Association in Lithuania, the Lithuanian Heart Failure Association. And I'm very grateful that she's with us today, representing Patient Association, but also representing herself as a patient, and will share with us her experience, which is always very relevant for this type of discussions. We will be talking today about iron deficiency. In November, we had a webinar during the day of Iron Deficiency Awareness Day. It's an important topic which is not so well known, even within the medical community. But we know today that up to 1/3 of the population suffers some sort of iron deficiency. And this is particularly relevant in patients with heart failure, where there is quite a substantial number of patients. In some series, goes up to 2/3 of the patients with some sort of iron deficiency. And that has, as we will see during this conversation, may have some important implications in the management and also in the evolution of patients with heart failure. So it's my pleasure to open this discussion. It's going to be a conversation among ourselves, the four of us, about this topic and some of the related issues related with iron deficiency. So maybe I start by you, Ali, Professor Taher, just to give us, in a nutshell, what is this thing of iron deficiency? What is the real significance? What is the burden? And how is it so relevant for the heart failure patient?
Thank you. I just want to re-say what you have already said, that iron deficiency is a very common problem, and it is often overlooked by the hematologist, by the general practitioners, and sometimes by the patient, because most of the time the symptoms might be similar to any other symptoms, so sometimes it is missed. Not only it's important in any person, it is very important in those people with inflammatory diseases or with chronic diseases, and heart failure is one of these chronic diseases. So it's a health-related problem where the availability of iron is not sufficient to that individual. And it is very important also to differentiate between iron deficiency and iron deficiency anemia, stating that not only every patient with iron deficiency would have anemia, and this is very important because in heart failure, the patient might have only iron deficiency, yet they might have symptoms and this might affect their quality of life, their ejection fraction, and living normally in their world. So there are several, so if I want to continue, there are several tests to make sure that to see if your patient is iron deficient or iron deficient anemia. A complete blood count, then you could see if he has a low hemoglobin or she has a low hemoglobin. However, the message should be that a serum ferritin, which is a marker that we use always to check for iron deficiency, is not a good marker in inflammatory diseases, specifically in chronic heart failure, because this is an inflammatory component in the heart failure, and these patients might have an increase in their serum ferritin, yet the saturation or the amount of iron is little and cannot be mobilized to the red blood cell. And as a result, it is very important that we should check the saturation of iron, percent saturation of iron, not only the ferritin level in this group of patients. So in here, I would end by saying that there are two types of iron deficiency. Either the store is empty, and a good example would be like a menstruating woman losing iron, or somebody bleeding. And the other part is where there is a store of iron but cannot be utilized properly. And a good example would be the heart failure. These are the patients where serum ferritin is not enough for iron deficiency.
Very good. I think that's a very important message, because many times that's not so well perceived, even by the medical community. But let me now move to Aiste. As a patient, do you want to share with us what was your experience and how do you feel this iron deficiency in your own experience? Would you mind to share with us what are your thoughts and what did you feel? And then if you would like to just elaborate a little bit, now moving into the patient association role that you have, how much can you as a patient in this leading position on the patient association help other patients also to understand this problem and maybe improve the way that patients may communicate with their own doctors?
Thank you, Professor. So my story is that I'm a heart failure patient since 4 years, currently living with a left ventricle assisting device. I'm waiting for the heart transplant. I have been iron deficient since the implantation of left ventricle assisting device. And I was constantly, and I am still constantly checked for the blood work of hemoglobin every month. And just following up to see if there are any decrease in hemoglobin, and then I get the treatment straight away. So now, as the situation we all know due to COVID is very difficult, it's kind of difficult to get into the hospital, into the specific unit, the heart failure unit where I stay, where my team is. Sometimes a couple of times I had to take the oral medication, the liquid iron to treat it, because in the other case I need to be admitted to the hospital and probably stay there for 1 or 2 days, which is again kind of a risk to get infected of COVID, especially if I'm in a risk group, if I could say. So it was definitely a challenge, and is still a challenge, but as I could say that I have a knowledge right now, not only about the heart failure, but iron deficiency. I know what to look at on my blood test. I always keep a communication with my HCP, and we always communicating in terms of how I can be treated and what would be the best way for me to do that. And talking about the awareness of iron deficiency, I think it is very, very important to relate that not only from the heart failure perspective, but in general. And in association, what we do, and we have a direct access to the patients, and it is easier to reach them and give the information needed. But then again, a simple way as a patient, if you have any symptoms, for example, a shortness of breath or, restless leg syndrome. So what we do as a patients, we normally go to Dr. Google and look for the symptoms. And then, we try to relate what the cause could be. But then finding the correct information, which is provided from the medical team, from the HCPs, this is the key. And our association in Lithuania, we are trying to only give away the information which is correct and valid, and as well given by the medical doctors. So we can avoid confusion in terms of, misunderstanding the symptoms, or maybe misunderstanding the information in general, or just the treatments and etc. It's always best, and not only best, but it's always recommended to check with your not only GP, but in my case, if I have a heart failure, I always check with my cardiologist. The one thing that
do you advise your patients to write down what they feel so they can not forget and communicate with the doctors, either the symptoms or any questions that they may have? Is that something that can be useful to improve the communication with between patient and doctor?
You know, from the patient perspective and patient association perspective, we do really recommend patients to write down the symptoms and to use any type of way to track the symptoms as possible, because we all are different and different ways works for everyone. From that point of view, we always ask the patients as well to, as we know the time is limited in terms of the consultation that we have in Lithuania is around 15 to 20 minutes max. So to keep a quality conversation and the time that we have with this medical specialist, we want the patients to be prepared to go to the consultation, right? So not only have the symptoms, what they felt, not only have the track of the medication, you know, maybe the treatments needs to change, and as well the questions that they might have during the time in between the consultations. The one thing that I really want to highlight is that the educated patient is engaged patient, and engaged patient is empowered patient. So it's very important to have that connection with your medical professional and keep in contact in terms of the symptoms or, you know, the worsening of the symptoms, which can happen during this time right now, while we are in quarantine and the lockdowns, and, you know, the access to the hospitals are quite limited. They are still there. The hospitals are open, but it is quite limited. So patients are basically told to stay home, and they are actually scared to reach help, and which, you know, ends up to worsening of the condition. And, you know,
absolutely, and that's a message that we really should convey. And we discussed this before, the need to tell the population, and the clear message that the hospitals, they have clear pathways, different pathways from COVID, known COVID patients. And it's very important that if a patient has a problem, that should contact the doctor. If it's an emergency, contact the emergency service and go to the hospital, because many conditions that have good treatment, the best treatment is when they come on time. And I'm talking about now also my own field in cardiology, where we've seen a lot of people coming late, and conditions that could be treated easily, actually they have been missed the opportunity to do that, and that can have disastrous consequences. So I think this message is very important, and all of us, you know, medical community, patient organizations, I think we really have to make a strong voice and make sure that we convey through all the channels that, please, if you have a problem, contact the doctor, contact your physician, your health professional, and if it's an emergency, don't hesitate and come to the hospital, because conditions that have treatment, they can be, if they are delayed, the window of opportunity can just go, and that can be a real problem, as we've seen around the world. This was actually a global problem. Antonio, many of these patients, they have comorbidities, and we know that that may affect not only the assessment, but also the natural history of many of these conditions, where iron deficiency is one of the issues. So what sort of comorbidities do you look for when you see a patient with iron deficiency, if you want, or patients with other conditions where you look for iron deficiency? So basically, how much these different comorbidities can actually affect the way that we assess for iron deficiency?
Thank you very much. And actually, I think that is a crucial issue, is that patients who have chronic heart disease and have iron deficiency often have symptoms that are difficult to distinguish between one another. Now, Aiste very elegantly put forward what sort of symptoms they look for and what patients should look for in symptoms. And I think that's a very important alert, is that symptoms can be a sign of something else other than just the heart disease, and that everything should be investigated. And in fact, patients who have congestive cardiac failure often have difficulties in absorbing, and that is one of the causes of the iron deficiency, because they have increased swelling of their intestine, and this makes it difficult for the iron to be absorbed. But also, a lot of the medication makes the blood more fluid, And antiaggregation, such as aspirin or anticoagulation, may make patients bleed more, with low-grade bleeding from their stomach or their intestine or elsewhere, making them lose iron, which is then difficult to put again. But we must also remember that patients who have chronic disease have a chronic inflammatory state. And this chronic inflammatory state often produces substances that make the bone marrow work less well. And so this chronic inflammation, even when the iron is sometimes replaced, may lead to difficulty in producing blood long term and aggravate symptoms. And this is something that also needs to be tackled and looked at. And finally, there are other organs that are affected in chronic heart disease. There are some congenital chronic heart conditions that affect only the heart, but there are acquired heart diseases, the most common being coronary artery disease and arterial disease, that also affect other organs such as the kidneys and the liver, etc. And therefore, these organs must also be looked at to try and correct the causes for anemia. So this sort of multidisciplinary approach and multifactorial approach needs to be present all the time when we're looking at patients with chronic diseases, and more poignantly in patients with chronic heart disease.
Absolutely. And I think this is a very important message, because sometimes we tend to look, or some of us tend to look at the specific organ, and we forget that the organ is in a patient who has other connections and other implications of a certain condition, as you just mentioned, with other either developing new conditions or exacerbating some of these conditions. And as we know, the relationship between the heart and the kidney is one of the conventional ones, and something that we have to look at and to make sure that we have proper assessment, so we can do then the proper management. And talking about management, Ali, we have different formulations that we can use to try to manage iron deficiency, and we have long-acting, short-acting formulations. You want to talk to us a little bit about that? What's the difference when you use one or the other, and what could be more convenient in some conditions, like, for instance, a patient who comes with heart failure?
Okay. So we have two formulations for iron replacement. We have the oral formulation and we have the intravenous formulation. In the intravenous formulation, we have two different types. One is long-acting and one is short-acting. Now, from the explanation that Antonio gave us on the reasons why these patients might get iron deficiency, a major component is the inflammatory process, as well as the absorption and taking other medications. So all of the studies that have been done in patients with chronic heart failure showed that intravenous iron is by far superior to oral iron in this group of patients. Actually, it is the recommendation by the hematologist as well as by the cardiologist, and we have very good data showing an improvement in their quality of life and survival in this group of patients. And the IV iron given to this group of patients is mostly the carboxymaltase, which is the long-acting iron, where we have seen major change in the quality of life as well as in the life of the patients. The oral is not really of good for this group of patients. Absorption problem, compliance problem, lots of medications. So moving into the IV has made a major difference in this group of patients.
Very good. I think that's very crucial and very relevant. This type of understanding what could be more efficient in one condition or the other. Aiste, what sort of recommendations, now talking to you as a leader of a patient organization, what sort in particular with heart failure, what sort of recommendations do you think are more efficient that you provide to your patients in terms of increasing the awareness? And now we can even go beyond iron deficiency. So basically, how can you as a patient organization in a way be an educator? You just mentioned that the patient educated will be basically better treated in a way. But how do you do that in practice? What sort of arrangements, what sort of educational material? So what sort of, let's say, strategy as a patient organization do you use to increase, on one hand, the awareness of the patient, but also, which I think is very relevant, and particularly now talking as a doctor, to improve patient-doctor relationship in the sense of the patient providing the best possible information so the doctor can use that to basically have better judgment.
Thank you, Professor. The best, the optimal, and the best way of increasing the awareness and attracting the attention of the patients in regards of raising the awareness are the events that, for example, our association do in Lithuania. So obviously the association have been around for more than 4 years, and the events have been continuously every year inviting the patients, and not only patients themselves, but the HCPs along together to not only raise the awareness, but as well educate them how to, for example, take care of themselves. I'm talking particularly about the heart failure. So how to take care of themselves, how to, what lifestyle changes to do, the diet, the exercising. And we are very lucky to have as called as a heart failure cabinets, if I can say that. So the patient has around 4 appointments a year along together with a heart failure nurse to go through all the journey in terms of how to, how to take the medication, how to, when to take them, because we know the younger patients, they are more motivated and they are more keen to know about the disease and, spread the awareness and share it. But it is sometimes problematic with the elder patients because they're not, it's either they don't want to know anything about it, they're not keen, they're not interested. That means that they're failing, to take the medication, they are failing to do the lifestyle changes, and basically they don't want to help themselves to live a quality life with their disease. And there are some patients who are really get a big burden for the emotional part. Those who are probably, need a psychologist or psychiatrist to help in terms to deal with this, as we say, the heart failure. When you hear heart failure, and probably Professor Taher can agree with me and give his opinion on that, because when we hear failure, it means that the organ failed us and our life is over. And again, if we go to, and I did that myself from my experience, when I heard the diagnosis of heart failure, I went to Google straight away, and what I've seen was like within 5 years, every 5th person dies from it. And I was in shock. I mean, I'm a young person. I don't want to die. I want to help myself. So what I did, I completely followed my doctor orders because I really wanted to get better. Obviously, I had some setbacks. But I'm really working on it, and I'm putting everything, all the attention and all the power that I have in terms of to help myself and to help living that quality life. And this reaches out to the my cardiologist and my team as well. The collaboration together that we have is, we keep in a communication all the time. We are sharing the information in terms of, what tests I need to do, when I need to come for a visit, and our communication is more fluent at that point. So as me leading the association, I really try to give that through my experience, because I experienced it, and I try to educate, and not only educate, but just simply talk about, because, education is good, but sometimes, and most of the times, patients just want an honest conversation. It's either with a professional cardiologist or medical professional, or with a patient, the other patient who went or is going through the same what they did. So yes.
Yeah, that's part. Absolutely, that's part of the soft skills that we also try to teach to our students and to our residents and fellows, but that's something that, with experience, and it grows up in the let's say in the evolution of doctors. But what you mentioned is very very relevant, because the way we communicate, even the words matter, as you said. Just the word failure really can, sound like a failure, which may be very negative. And I think one of the elements of good practice is actually to have patient engagement in his or her own treatment. And to do that, we really have to have good communication, doctor, patient, which in a way, modern medicine, because it's very much multidisciplinary, and particularly if you are at the hospital level, you may actually be confronted with different specialties, with different doctors, with different health professionals. And that's really one of the challenges that we face now. It's to humanize medicine, and the way to do that with a good communication strategy for the team, which is something that in the old-fashioned way we were not so used to discuss and to deal with. Do you want to comment on that, Antonio? Because I know you also have a lot of experience in that.
Yes, no, thank you. And I think that the most important word that Aiste mentioned there was collaboration. And I think that's the key everywhere, from what you're saying and to what Aiste is saying, is collaboration between the patient and the doctor. And I think more and more, all of us see this relationship as a collaborative relationship, working together for the patient's well-being, but with the patient's contributing. It's much more of an active role, like Aiste is describing the passive role, but also collaboration between specialities and between teams. I think multidisciplinary action is crucial in chronic diseases. It's crucial in almost all diseases, but chronic diseases, it becomes even more important. And not only do we need this in our own hospitals, like we have them, but also we need this between disciplines like we're doing now. I think this initiative from the World Heart Federation to bringing in hematologists from the European Hematology Association to discuss these topics and bring them into focus and really promote education of physicians and patients to better treat is a very important and crucial in advancing medicine in this way.
Well, thank you so much, Antonio. Yes, please. I was going to ask for a final, because time flies and we're reaching the end. Final comments. So please, Ali.
I just want to comment on the importance of the voice of the patient. So patient advocacy is really something very important in all diseases, but in chronic disease, it's the most important. And if it's not for her voice, for Aiste's voice, a lot of patients cannot neither listen to their physicians nor to so we as physicians and specialized and subspecialized, we should empower our patient and identify those patients or those individuals that could be a clear, transparent voice, because this would be helpful for us, for the patients, for third-party payers, and for governments. And this is a good example, for example, would be chronic myelogenous leukemia, where the disease per se, with the voice of the patients, has made thalassemia, and now iron deficiency, anemia, and heart failure. These are all very important. So the voice of the patient, to me, would be, at the end, the most important component in this.
Very good. Aiste, any final comments? Any final take-home messages?
Well, I always say that, but with a good management, I think any disease in the world, if you take the orders from the doctors and you follow them, you do the lifestyle changes, you keep your positive outlook to your life, to your health, then everything can be managed and we can really live a long quality life. I think that's very important for the patients.
Great. Antonio, final comments?
My only final comment is really partnership between patients and doctors, like we're seeing here, and interspeciality in doctors from different backgrounds and different specialities to really improve outlooks altogether, like Aiste is saying.
Well, thank you so much. We reached the end of this conversation. I hope you enjoyed this exchange between doctors, also patient representative, on a topic which is not very much spoken about, but we felt was relevant to bring to you, iron deficiency and some issues related not only with the condition, but also how we, either as doctors or as patients, and basically collaborating, working together, we can basically be able to do better patient management, because at the end, that's what is really important, is how to make patients feel good, how to improve, not only from a medical perspective, but also in a holistic way, to feel better integrated into the society and having happier lives. That's what we want for all of us. So thank you very much for watching us. And thank you, Ali. Thank you, Antonio. Thank you, Aiste, and thank you to the World Heart Federation and also to the European Association of Hematology that hosted this webinar. Thank you.
Thank you.
Thank you.